It's a great honor to have this opportunity to speak with you today about the state of the healthcare workforce in the United States, and more specifically, to consider the workforce that we need to care for individuals with serious illness. I'm pleased to be here on behalf of the U.S. Department of Health and Human Services and as director of the National Center for Health Workforce Analysis. As you know, the year 2030 will mark an important demographic turning point in the United States history. That's the year when all baby boomers will be older than age 65. Older individuals are also projected to outnumber children in the U.S. for the first time in history. This demographic shift will have massive implications for the U.S. healthcare system. At the moment, healthcare spending is approximately 18% of the U.S. GDP. However, only 5% of the population accounts for approximately half of all healthcare spending. In terms of utilization rates, individuals over age 65 are disproportionately represented in the highest spending tiers, and the oldest older adults, those over age 85, have the highest per capita utilization of health services. Taking age out of the equation, the population of the population that have the highest healthcare costs, more than 75% have one or more chronic health conditions. Before I address the state of the U.S. healthcare and health support workforce, it is important to hear the bigger picture context. At the moment, there are 4 high-level policy priorities within Health and Human Services that have been set for the entire U.S. These include stemming the opioid crisis, a topic where workforce is critical to the solution; value-based care, which of course we have been aiming at for decades, but a shift which, if truly accomplished, would have huge ramifications for improving the quality of care for not only those with serious illness, but everyone; health insurance reform; and lastly, drug pricing. Further, I would note that there are 2 policy topic areas that are gathering attention, which are integral to those interested in workforce issues. Those are achieving health equity and having the workforce that enables it, and training the workforce to truly understand and address the social determinants of health. This is something which those of us who have worked in the areas of aging, disability, serious and chronic illness have been shouting about for a long time. When it comes to the U.S. healthcare system, I like to describe it as a patchwork quilt. There are several components between those entities that provide care, those that pay for it, and individual consumers. Unfortunately, in a disparate system like ours, serious challenges exist when attempting to provide access to healthcare services for those who are heavy utilizers. Given that we know those with serious illness are heavy healthcare utilizers and cost drivers, the sufficiency, distribution, and quality of the healthcare workforce are increasingly important puzzle pieces to improving overall population health. By sufficiency, I mean how many are in occupation and do we have enough, too few, or too many. By distribution, I mean where are they located. And by quality, I mean how good is the care they give, or what can they or are they allowed to do. While all 3 topics are critically important, insufficiency and maldistribution issues significantly complicate the healthcare landscape, because they can immediately constrain access to essential care and treatment for millions of individuals. In other words, one can argue that if a consumer does not have physical or virtual access to a particular type of healthcare provider, they do not have access to the type of care that person offers. In terms of sufficiency, the U.S. healthcare workforce is composed of a diverse group of clinical and support occupations, and currently there's no consensus on who is considered part of the workforce for those with serious illness. For example, those occupations providing long-term and palliative care are often considered the backbone of those who provide services to individuals with serious illness. However, given the fact that this population are heavy utilizers and long-term services and supports, as well as healthcare in general, they access many different healthcare and health support providers. Thus, I would posit that any healthcare or health support occupation should be considered a part of the workforce treating those with serious illness. Which brings me to the other critical workforce access issue, which is distribution. In my years of examining labor force composition, participation, and migration, I would argue that more critical to this nation than determining or addressing shortages or oversupplies for a specific occupation is the issue of maldistribution. Unfortunately, it's not uncommon for many healthcare occupations, and perhaps is more of a factor of complex socioeconomic determinants which push or pull an individual to live and work in a given area. We must also push for continual improvement in terms of workforce quality, such as encouraging cutting-edge curriculums, training for work in various specialty settings, and unique treatments for special populations. To that end, building, redistributing, and/or reshaping the healthcare workforce must be aligned with other efforts to address social determinants of health and to improve overall delivery of services to individuals, including those with serious illness. Further, we must move toward improved coordination and interprofessional training in teams. Of course, understanding and being able to address these issues starts with an evidence base. Unfortunately, as is the case in the healthcare workforce, data in the US is good, but not great. This is certainly a symptom of our disparate healthcare system. Given, for example, many occupations are licensed at the state level and others are not licensed at all. Within this complex system and context, the Affordable Care Act mandated the National Center for Health Workforce Analysis. This was in clear response to the growing need for increased research and information on the workforce powering this sector of the U.S. economy. In terms of the breadth of health services research under our purview, one of our larger mandates is to produce projections for occupations in healthcare. In 2013, we developed what is now known as the Health Workforce Simulation Model. Put simply, this is a very specific, predictive model which estimates current day supply of a given occupation and then current day estimates of demand based on utilization rates for that occupation. It then projects outwards 15 years, and if supply cannot keep up with demand, we say the occupation is in shortage. If it predicts supply will be greater than demand, we say the occupation is in oversupply. Listed on my slide are several of the occupational areas where we have produced projection estimates in the past 5 years. Quite often, we find that if nothing changes, if there are no shifts in utilization, 15 years out, we will see shortages of workers in the majority of healthcare occupations. The main driver in this model for that problem is actually the aging of the population. That said, we all know the amount of services currently being utilized will likely change 15 years from now, and indicators point it towards being more utilization of health services, not less. One way we've tried to tackle this is when we come up with alternative scenarios to this baseline. We think of these as what-if scenarios. So, for example, what if we were able to improve population health in certain domains, thus allowing us to age healthier? Or what if we improved access to services for certain segments of our population who experience health disparities? What workforce might we need then? While these types of intellectual exercises are important, they're substantially less firm foundations on which to build programs and implement policy. To that end, we've also moved further into the areas of generating foundational data, such as the National Sample Survey of Registered Nurses, which is the only survey of its kind and size in the US, and reporting on current day descriptive indicators of the healthcare and health support workforces. In fact, right now we're generating and reporting very straightforward information on the US health workforce and system to the World Health Organization, which will ultimately allow for member state comparisons across the globe. So to summarize, the nation's healthcare and health support workforces are evolving, whether that be in size, location, or along other dimensions such as quality. These trends are not necessarily unique to the United States. Of course, in the healthcare sector, the main drivers are those with serious illness and the aging of the population, which are interrelated and overlapping. Better understanding the demand for, quality of, and supply of these occupations is critical to providing individuals with serious illness access to essential healthcare services. Thank you.